Hi, I'm Dr. Randy Martin. We're here at the AATS Mitral Conclave 2017, and I'm pleased to be joined by Dr. Pedro del Nido. Pedro, you need no introduction to our audience, which is great, for positive reasons, not for negative reasons. But so the obvious question comes, you've had extensive experience. Tell me your choice or the pros and cons of valve choices. I'm not going to say in children, but let's say in teens or young adults that you would operate on.
Right. You know, obviously in today's world, a lot of decision making is made by the families and by the patients, especially in older teens. So we can recommend, but at the end of the day, you know, it's their lifestyle. So that's really the choice. It's no longer a function. I think it's more of a lifestyle. One is the choice of obviously anticoagulation, limited activity. And you know, you can say, well, you know, they're compliant, they're good, but kids are kids, and they will forget and they will do things. So I think we have to remind parents of that. And in general, I would say probably we are 80% tissue valves and 20% mechanical, and usually the mechanicals is mostly by choice of the family. And that's true really pretty much between aortic and mitral, probably less so mechanicals and mitrals, just because of the need for higher levels of anticoagulation.
Is that sex related to in choice? In other words, if you've got a young female?
Yeah, absolutely. We always tell them that yes, you can have a pregnancy with a mechanical valve, but it's very complex and you would need very close follow-up. So generally when most of the time they haven't even thought about these issues because it's not even it's something that would be way far ahead in their future, but they still have to think about it. So that's why we point this out and we say, well, you know, the technology also is improving for the tissue valves. The valve-in-valve is a reality, and as long as we can put in something large enough, then it's an option for them.
So it's really, I mean, size then becomes a determinant of the tissue valve for valve-in-valve. Pedro, what do you tell them about durability? I mean, our longevity. Obviously, we think the mechanicals will last longer. Is that the...
Right. Well, for us in small children, reoperation is there regardless. Because they're going to outgrow any mechanical valve that we put in. But there's no question you will get an extra 3, 4, sometimes 5 years out of a mechanical before you need reoperation. And part of that is just because you're not worried about the durability of the leaflets. But on the other hand, pannus formation for us has been a real problem in the mechanical valves. And so dysfunction, even of some of the latest designs of valves, we've seen pannus forming that interferes with the leaflet forming that has caused us to go back in and replace.
Why pannus? Just the young autoimmune responses. I mean, everything's geared up.
That's part of it. The other
response.
part is that often we're putting in a fairly tight valve into a very small space, and so ingrowth is, I think, a lot easier. So we don't, obviously a young child will have a much more aggressive response to these mechanical valves or to any prosthesis, and so I think that's part of the issue. But we see the pannus in tissue valves also.
Really? Okay, that's interesting. What's new on the horizon of the child or the young adult with congenital heart disease? You're going to grow valves. You're going to design valves. What's coming down the future?
The tissue engineered, take your own tissue and grow. I think we're going to still be waiting for that for a while.
Okay.
But what we have done is we have taken the simple concept of an expandable valve. And as long as the leaflets are designed so they can still coapt at bigger diameters, then that works. And so we have a valve that does that. For example, the Melody valve is a transcatheter valve, but we put it into the mitral position. We certainly have put it in the aortic position, and we've shown you can expand it and still leave a functioning valve. So in a young child where growth is really the big issue, I think that's going to be ultimately an interim solution until we get the Holy Grail. The Holy Grail, we may wait for a long time, but this is something we have today, and it's both in the clinical, it's obviously off-label use, but nobody makes on-label for children. But the other option is there's work being done in the laboratory to design new valves that have a similar design as a venous valve. Venous valves are interesting. They work, if you look at your leg vein valves, they work when the vein is like this, and they work when the vein is like this. They're designed to do that. So we started looking at mimicking the shape of the leaflets to design a valve that actually works.
When you say they're designed, is it because of their length or the way that they can...
Right, it's the height of the commissures, as well as how much leaflet tissue there is.
Okay, it's the height of the commissures. That's interesting.
I didn't design them. I think someone else did.
So let me ask you, are there lessons that we have learned, that you've learned over the years with your outstanding work, that would transfer to the adult? 50-year-old, 45-year-old who needs a mitral valve replacement?
Yeah.
Do we know, I mean, are there lessons that are there?
Well, I think one of the things that we're already seeing is the idea of expandability of these tissue valves, I think, is entering the adult world. And the reason for that is because of the valve-in-valve. And already we're seeing products that are coming out. So I think that idea is already here.
You're talking about annular expansion.
Annular expansion,
okay, the
exactly.
capabilities to do that.
Yeah, I think that's already here. All you need to do is design different leaflets, and now you'll be able to change the diameter of those valves by a lot, potentially, when you have someone who's either gained body mass and has real dysfunction of or mismatch, I should say. You'll be able to treat that. I think the adult world is also seeing anticoagulation as problematic, and many people, and I know that when you're in your 50s, you still feel pretty young, and you want to be active. So I think it's a value choice, and I think we have to offer it to our patients. So improving the durability of those valves is still important.
That's super. Well, listen, you've done super work, over the years, and have certainly taught us a lot about that. So thanks very much for joining us.
No, my pleasure. Thank you.
And thank you. We hope that you'll come back soon.